and exercise.
Okay.
We are going to ask for a budget for a project with a unit that they are in charge of mental. They are a research group.
Yeah. You're waiting for the people, or? Whatever you prefer, we can wait if you want. Okay. Yeah. Maybe you can take the microphone.
Okay. Well, good afternoon, and thank you for your attendance today. Okay, I think that you've had the chance of quitting a little bit the Bilbiche campus and having an insight at as well the School of New Technologies of New Technologies from the University of Barcelona. Well, today is a pleasure to introduce you to Mr. Kamenov, academic doctor and research scientist for World Health Organization. So, well, Mr. Kamenov will be presenting, will be providing you. So he will be providing you with a little briefing on the work that he's been doing in the World Health Organization, WHO, alongside the Global Strategy on Rehabilitation 2030. Well, it's a real pleasure, and thank you very much for being here.
Yeah. Hi, everyone. First, I would like to express my gratitude to Mariano for inviting me here. It's a pleasure and an honor for me to give this talk. And I know Mariano since last year, actually. He's a great guy, so I'm sure you're all in good hands here. So a little bit about myself. My name is Kaloyan, and I'm originally from Bulgaria. And in the last 3 years, I've been working for the World Health Organization in Geneva in the unit for rehabilitation, disability, prevention of blindness and deafness. And I'm not rehabilitation person, actually. My background is in psychology. So I did my PhD in Madrid, in the Autonomous University of Madrid. And then I worked for some time in the field of mental health, and then I swapped professions a little bit, and I started working for WHO on rehabilitation mainly. And so in this sense, you know much more about physical therapy or rehabilitation, at least on a clinical level, compared to me. But when Mariano invited me, he asked me to present a little bit the research methodologies that we've used in different projects at WHO. And there are many methodologies that I'm sure you also learned throughout your degrees, mainly applied on a clinical level. So I don't know, for example, how to see if a certain intervention is effective for a particular condition. But the research normally that we're doing at WHO is a bit different. It's a system level research. So we are developing tools, for example, to help ministries to improve their rehabilitation system, or, for example, to decide which interventions should be included in hospitals and should be provided as part of the health insurance. And that's why I was thinking that instead of just speaking about some projects that I've been working on, it's better if I give a more like a overview of the whole work on rehabilitation that WHO is doing. The whole concept of rehabilitation and the way WHO works on this field changed 2 years ago. And so I will present some of the projects that we're working on, speaking mainly in terms of the methodologies that we have applied, and also, present the areas of work. So just to outline how I have planned these next few hours, I will start first by presenting the concept of rehabilitation, the way WHO sees rehab, and also what is the global need for rehabilitation. I will present some data on this, and then I will start presenting different projects and the research methodology behind them. And I'm sure that if I only talk, you'll be all bored and fall asleep. So at some point, I'll give you a very small task to work in groups of 2 to 4 people. And then we can have a break, we can discuss this task, and then I will continue with the presentation. So does this sound good for you? Okay. So before I start introducing the topic, I would like to play a very short video. This was created 2 years ago by us and presents the
rehabilitation. It restores the ability to move, think, see, and communicate. In the 21st century, health systems are confronted with new challenges. With global aging populations and an increased number of people with chronic conditions, more people are living with disability than ever before. For health systems, this means a shift in services that don't just reduce mortality, but improve functioning and quality of life. And this is what rehabilitation is all about. As countries develop and health services improve, rehabilitation is needed to make sure people get the best possible outcome after an injury or illness. It means getting out of the hospital sooner with less risk of complications and less need for ongoing support. But in many parts of the world, people don't have access to the rehabilitation services they need. Insufficient numbers of trained rehabilitation practitioners, lack of services, and barriers to access, such as high out-of-pocket expenses, are challenges we have to address. Rehabilitation is key for the health of populations in the 21st century. Now, more than ever, we need to take action to ensure that everyone can access quality, affordable rehabilitation services.
Okay, so what is rehabilitation? it's a key for optimizing healthy life expectancy. So basically it adds years of healthy life in the lives of people. It's also a key for reducing disability and optimizing functioning associated with chronic conditions or impairments. So every person with a chronic condition or impairment has a certain level of disability. It can be mild, it can be severe. So imagine, I don't know, like Messi getting injured, and he's not going to be able to play in the next 3 weeks. And he can do perfectly all daily tasks, walk, talk, wash, drive a car. But then one very important functional domain in his life, work, is basically limited. And we can think of this as mild disability, but he still needs rehabilitation in order to get back to work. And then someone with, for example, spinal cord injury has a severe type of disability because he can't do independently most of the tasks, daily tasks, and he needs support. And it is a severe disability, but in any case, everyone with a health condition needs rehabilitation in order to reduce the disability and also to improve the functioning. Rehabilitation is also effective in improving clinical outcomes, like symptoms, for example, and it's important in every stage of care, like acute, post-acute, or long-term care. And studies show that it's cost-effective. So this means that when you invest in rehabilitation, then you will gain as well more. And it makes a huge difference in people's lives. So like imagine someone with spinal cord injury here in Spain that has access to rehabilitation, has a wheelchair, social support services, and family that can support him. And imagine the same person, for example, living in sub-Saharan Africa without any access to rehabilitation, without a wheelchair or a social support. And the only person that he is dependent on is his mom that takes care of him. So you can see that a person with the same health condition has a completely different life, and rehabilitation and assistive technology is very important for his life. So given the importance of rehabilitation, as you can imagine, of course, there is a huge global need for rehab, and this need is increasing. And why is it increasing? First of all, there is a demographic and also health shift in the population in the last decades, let's say. If in the 60s and 70s, a lot of people had infectious diseases, now the number of people with infectious diseases is declining because of vaccines, because of technology, because of better medicines. But at the same time, people living with the consequences of injuries that need rehabilitation is not really changing, but at the same time, it's still very high. But what is increasing is the number of people with non-communicable diseases, so musculoskeletal conditions or cardiovascular conditions or diabetes or cancer. And this number is increasing in every single country in the world, and you will see a little bit later, I will demonstrate this. And there is also another demographic change, and this is the aging population, because people above 50, the number of people above 50 is increasing constantly. And these are also the principal consumers of rehabilitation. So that's why the need for rehab is huge and it's increasing. And we calculated that 74% of the global burden of disease, which means that we took all diseases for which we have any type of information, as for example, prevalence or number of deaths or incidents, and we selected these ones that we know that they might at some stage need rehabilitation, and 74% of this burden of disease is linked to conditions for which rehabilitation is beneficial. So it's a huge number. And I can show you here, we selected the 15 conditions that are associated with the most severe levels of disability and for which we know that rehab might be beneficial. And you can see the change in prevalence, so the number of people between 2005 and 2015. And on the right side, we have years lived with disability. So I'm not going to go into detail, but this is an artificial estimation that is basically the combination between the prevalence, so the number of people with the condition, and the severity of the disability. And you can see the change, like if in 2005, 62 million people had cancer, now there are 90. For chronic kidney disease, for example, you had 250 million, now we have 322, and this is just in a change in 10 years. So more and more people would need rehabilitation at a global level. So on one hand, the need is increasing, but at the same time, the demand for rehabilitation is low. And something else is low. This is the supply, so the provision of rehabilitation. And why is that? If we talk about the demand, there is just low awareness, which means that people are just not aware of the fact that they need rehabilitation, or that rehabilitation is accessible, or that it might be beneficial for them. And for supply, it's just the low capacity. There are no resources in countries. So in some countries, you don't have rehabilitation at all included in the health systems, or you don't have enough facilities, or, for example, workforce in order to practice. And so we did a study, and in this study we wanted to see what is the global need, and also what is the provision of rehabilitation, and what is the relationship between both. And we saw that in many low and middle income countries, more than 50% of the population who are in need of rehabilitation actually don't get the services. And unfortunately, there is no data from these countries. The majority of the studies are done in high-income countries like the United States, Spain, if you want, or the Netherlands, for example. And the reasons for this is that, first of all, there is lack of services. Then there is lack of transportation. So many people living in rural areas, they can't go to the closest hospital that's like, let's say, 150 kilometers from them, because they don't have a transportation or proper vehicle. Another reason is unaffordability, because here in Spain, you're lucky because you have universal health coverage and everything is covered. But then in many countries, you have to pay in order to get, rehabilitation. I'm from Bulgaria, and you have 7 sessions. Whatever your condition is, you have 7 sessions included in your health insurance, and then you have to pay if you need more. So, and we're speaking about the country from the European Union. And then lack of awareness, as I said, just people are not aware of the importance of rehabilitation. And like when I started working, the first thing that I had to do was to see what is this relationship between the number of skilled rehabilitation professionals that you can see on the x-axis, and then what is the number of people that actually need rehabilitation. And surprisingly, this data is just not available. Even in high-income countries, like if you ask someone in the ministry how many physiotherapists you have practicing, they just don't know. They don't keep record of this. So the only thing that we could do in order to see this is to check some professional organizations. For example, the World Federation of Occupational Therapists, or WCPT for the physical therapists. And we asked them, because normally people who work in countries, like the professionals, they register. So we asked them, okay, how many registered members do you have in these countries? Even though this is not really a representative number, because in many countries, not everyone is registering, because you don't really get any benefit. You meet with some other colleagues, or you have some newsletters that you receive, but it's not really, you don't get money, for example, for being a member. And you can see here, like the orange and the blue rectangles that represent the low and middle income countries, like everything is almost like stick to the y-axis, because there are no rehabilitation professionals. But at the same time, the need is big, because there are many people, millions of people who need rehabilitation. And if you check like different rehab professions, like for example, the density of prosthetists and orthotists per 1 million population, you see a huge difference between high-income countries and the rest of the regions. So, for example, you have, even in high-income countries, you have a little bit more than 2 per 1 million population, and according to WHO, you need at least 5 in order to cover the basic needs of the population. And for occupational therapists, you have even bigger difference between high-income countries and the rest of the regions, and you need like 750 in order to cover the basic needs. And even in high-income countries, normally the mean is like around 400. Now, physiotherapists, it's a little bit better, but still, we don't have, unfortunately, a number that is required to cover the basic needs. But what we know is that it's not enough, like the number is not enough. And then for PRMs, or for physical and rehabilitation medical doctors, it's pretty much the same. And the last one is the speech and language therapists. Here we didn't really have data from many countries. That's why we haven't combined it in regions. But you can see like the difference between the USA, where you have around 500 per million population, and then most of the African countries, they have 0, like maximum 10. So given this fact, like that you have a big need for rehabilitation, but at the same time, like the supply and the demand are not very high, WHO made a commitment to change this because, to be quite honest, in the last 60 years, rehabilitation was really neglected in WHO. The last formal meeting organized for rehabilitation was from 1957. So it was like 60 years. I'm not saying that nothing was done, but pretty much nothing. And that's why, so we made a commitment to change this thing and to increase the demand and also to increase the supply in countries. So basically to provide people, countries with technical support in order to change this fact. And in 2017, we had a big meeting with different stakeholders. So it was ministers of health, NGOs, academia, so editors of journals, also rehabilitation users. And in this meeting, what we did was to present 10 points. It's like 10 recommendations that countries should follow in order to improve their rehabilitation system. And these 10 points are, in general, they encompass like all the building blocks of the health system. So, for example, political support for rehabilitation, integration of rehabilitation into the health sector, also better quality services, including assistive products, or ensuring a better and multidisciplinary rehabilitation workforce, or more financing, so more funding for rehabilitation, better health information systems. So this means that like when you go to a doctor and normally you have a record and whatever he prescribes or does, it's kept in the record, but this is not the case in more than 80% of the countries where everything is on a piece of paper. And of course, building research capacity, so more research done, and countries should do more population-based studies in order to know what the, to inform policy and to know what the need for rehabilitation is. And these 10 points are basically also driving the work of WHO in the field of rehabilitation. So we have 4 areas of work, and they're all aligned with these 10 points. So, for example, the first one is advocacy. So we are basically trying to raise awareness and to cover the demand, so this arrow of the demand, in order to raise the awareness not just in terms of governments that have to be aware that rehab needs to be improved, but also people who need to know that rehabilitation is beneficial for them. Then the second area of work is health system strengthening, and this is basically the biggest one. We have a lot of projects there, and here the idea is to create tools in order to support countries to, improve their rehabilitation systems. Then the third one is research and evidence. And of course, in all the projects, we have research methodologies behind everything that we're doing, but there is one area that is specifically for research and evidence. And there I will present one global status report that we are now working on a little bit later. And then the fourth one is the emergency situation. So we want to make sure that there are rehabilitation specialists in, let's say, the case of emergency or a disaster. So very briefly about advocacy work. We have regional offices in each of the 6 regions in the world. So it's they're a bit different. They're not like continents. So for example, Europe also includes some countries from the Middle East. Normally what we're doing is organizing every year a meeting with relevant stakeholders in each of these regions. So for example, ministers or NGOs or anyone who is responsible and works in the area of rehabilitation, and we are providing them with updates about our work. They're saying, for example, this country needs this thing, and then we start working on this. So it's more like raising awareness, like keep everyone updated on what we're doing and what the countries need. And this is pretty much the advocacy work. It's not much. It's just like spreading the word and then seeing where the need is for further work. And then the health system strengthening. This is the second project. Sorry, area of work, and there are different projects here. What leads the whole area of work is this knowledge that we have, and this, let's say, decision that we've taken that the only way that rehabilitation should be better and should be, function better is if it's part of the Ministry of Health. So the Ministry of Health in every country should be the one responsible for rehabilitation, like here in Spain, for example. But in most countries, it's actually the Ministry of Social Affairs or Ministry of Education, and things just don't work there because we think that rehabilitation is a health discipline. And we think that rehabilitation should be provided along the whole continuum of care, so from acute to long-term care, and at the same time should also be provided in each delivery platform, so the community-based, then primary health care, then secondary health, so the hospitals, district hospitals, and then tertiary, which is basically the specialized rehabilitation centers. And the second thing that we also know is that it's an intersectoral discipline, which means that it has a lot to do with the social or the labor market, or with the educational system in the country, or for example the financial ministry. But still, the Ministry of Health should have the stewardship role for rehabilitation. So the first thing that we did was to publish this book. It's called Rehabilitation in Health Systems, and this book contains several recommendations. I don't know, I mean, maybe you don't see it very well, but basically these are evidence-based recommendations that countries should follow in order to improve their rehabilitation system. And this includes things like, for example, to ensure that hospitals include specialized rehabilitation units for inpatients with complex needs, or, for example, ensure that there is availability of a multidisciplinary rehabilitation workforce. So these are several recommendations. You can access this. I will then later share the slides with Mariano, so he can send them to you. And you can see a little bit more this, and also see the link where you can access the this book. And I will tell you what was the methodology, how did we come up with these recommendations. So at the very beginning, we had to decide who was involved in this. Of course, this was WHO Secretariat, so these are the people who work at WHO. And then we needed also like an external group of experts that will advise us on the whole, like during the whole process, and they will give their expertise. So these were people from different countries. Like we need a representation of men and women, of course, like different age groups, and also different regions of the world. And these were the people that we were working directly with. And then, of course, we also needed someone to review this work in order to make sure that this is like independently done and it's also evidence-based. And we had this external review group. So every time when we had a draft of what we were writing and doing, then we were sending to them, and then, you know, they were the ones who were providing feedback if something was okay or something was not really working well, so we had to change. And normally, every project, and I'm sure that you will see later when we have research subjects in your degrees, you see that when you're doing, for example, literature review or meta-analysis or whatever, you have to start with a research question. So you have to know like what you're looking at. So normally what you're doing in this case is to follow the so-called PICO format. So you have to identify your population, your intervention, your comparison, and your outcome. And in this case, we had already a population. These are everyone, like all the people that need rehabilitation. Then you have we had already the outcome, and this was normally the outcome that was aligned with the outcomes needed for the universal health coverage. So better quality care, or more workforce, or, for example, more people receiving rehabilitation. So what we were missing were the interventions and the comparisons. And we had several questions. I have included here just 4 of them. For example, should rehabilitation services be integrated into the health system or into the social or welfare system? Then should rehabilitation services be integrated into primary, secondary, or tertiary level of the health system, or integrated only in like one of them, let's say? Or should a multidisciplinary or single disciplinary rehabilitation workforce be available? So this type of questions were outlined. And then in the next step, we had to get the information. And how did we get the information? By first series of systematic review. So we wanted to check what is out there in the literature and then obtain this information. We also checked some gray literature, so basically not scientific literature. So this means, for example, administrative data or information from hospitals or information, I don't know, from some governmental reports. And then also the guideline development group, they provided some not published, unpublished evidence. And then after we did the systematic reviews, then we had to check what was the quality of the results that we found. And that's why we followed the grade process, which is the grading of recommendations, assessment, development, and evaluation. So there are some certain indicators that you have to check when you, let's say, you find that a certain intervention has a lot of papers published on it, and then you want to check what is actually the quality of this, what is the quality of the literature, what is the quality of this intervention. So using this grade system, we could rank all the results that we found in 4 categories. So high quality, moderate, low, or very low. And of course, if something was very low, then we just didn't include it. And after we finished with that, we had to, the 4th step was to review if what we have found is actually feasible, if countries can, accept this, and if countries can provide this type of intervention, because it can perfectly work in a high-income country, but then in low-income country, you don't have the necessary resources in order to implement this. So we have to think how to adjust this. So this was the 4th step. And then, of course, after we reached an agreement, we formulated the recommendations and we documented the preparation. We prepared the documents and then published it. So this is very briefly describe the methodology that we followed, and this is a methodology that we follow in many other projects where we need to assess the literature and we need to come up with the evidence-based information or certain, let's say, intervention or any other type of information. So it's good to have recommendations that should be followed by the government, but then you can't just send the recommendations and say, hey, just follow this and you get a better rehabilitation system. Like, you have to actually work with them closely to assess the situation in the country and then to provide the technical support so that they can do the whole process in a good way. So the next project that we're working on is called Guide for Action, and it's actually a support package of on rehabilitation. So these are 4 steps that WHO, together with the government of a certain country, is working on. And in the first step, so for each of these steps, we have a tool that you can see on the right side of the slide. And normally this tool helps the focal points in the ministries to undertake the whole process and to evaluate it, etc. So, for example, the first step is to determine the situation. So when you go to a country, you don't really know what happens with the rehabilitation, so you don't know anything about it. And then what you're doing is to assess the situation. So you have to know who is responsible for rehab. Is there any strategic plan about rehabilitation in the country? Or let's say, do you provide rehabilitation in hospitals or not? In which hospitals? Are all the areas of the country covered, or you have just in the big cities and you don't have anything in the rural areas? You also have to know what is the need in the population. So you have to know how many people actually need rehabilitation, how many people have severe low back pain, or how many people have stroke or diabetes. So everything is done through this STARS tool, Standard Assessment of Rehabilitation Systems, and I will show you later. Actually, your task will be very related to this. This is a set of questions that normally someone who is responsible for rehab in the ministry has to, fill out and to discuss then with the person from WHO. And then once you know the situation in the country, you go to the next step, which is to develop a strategic plan. So now with all the knowledge, you know what are your priorities and where you should target. Like, so what are the gaps and where should I actually, invest more? And there is this guidance for rehabilitation strategic planning tool that can help people to do that. And then once you have already developed your plan, the next step is to develop a rehabilitation monitoring and evaluation framework. So you have the plan, but you have to know, first of all, you have to monitor how it works in the future. You also have to make an evaluation. So, I mean, maybe something is not right. Maybe you have to change it, or something is working good. So let's go in this direction. So this frame tool helps to assess this. And of course, the last step is the actual implementation of the plan that you have already created. So we tend to think of the whole process as a cyclical process. So you determine the situation, you develop the plan, then you develop the monitoring and evaluation process, and then you do the whole implementation. And the idea is that it's not going to happen just now, once, and then you just forget about it. But you actually do this every 2 or 3 years in order to learn from the mistakes, let's say, and to see where you need to make a change in order for this to work better next time. So this is, for example, the STARS tools, like just the first section, which is on rehabilitation needs. So this is part of the questionnaire. You actually, for example, how many people have trauma, or how many people have stroke per year, or what is the prevalence of age-related conditions. This is another section, for example, leadership and governance. Which ministry is responsible for rehabilitation in the country? Or has rehabilitation been included within health services planning processes? If yes, describe how, etc. So this is the type of questions that normally you have to answer. And the idea is that the health sector strategic plan in countries that normally in almost every country includes things like mental health, maternity and child health, or HIV, or NCDs, we also include rehabilitation, because only if rehabilitation is part of this strategic plan, then it will be prioritized and more funding will go to rehabilitation. And we started this process in 2018, and these are the countries that are now currently undertaking this exercise. So we wanted to have at least 2 countries from each of the regions. As you can see, normally high-income countries have already a very well working strategic plan on rehabilitation, and so it's more orientated towards low and middle income countries. And before I continue now with the next part, I would like to give you a task. So I will give you I have selected some questions from this STARS questionnaire. And I would like you to imagine that like you are people who work in the Spanish government, and I'm coming from WHO, and I want to ask you, what is the situation in Spain? So try to answer these questions. Like, I know that probably you don't know the answers of most of them, so you can, if you want, Google and try to find the answers of these questions. But it's not important if you know or you don't know. It's more like to get a sense of like how things work, and also to see if you know actually how things work in this country. So you can work like in groups of 2 to 4 people, and I'll give you half an hour to do this. And then if you want, after you finish, we can have a break, so you can relax a little bit. And then when we come back, we will discuss this task, and I will continue then with the presentation. Is it okay? Okay. Okay, so now it's like 3:45. So maybe until like 4:15, and then you can have a break. excuse me. So if you've more or less finished, if you want, you can just take a break. Now it's 10 past 4, so maybe until 4:30, and we can then start again. Is it too much? Or do you want like less time, or it's okay, 20 minutes? Okay, 4:30 then. Let's start again. Okay, are you ready to start? Okay, are you ready to start now? Thanks. So how did you find the task? I guess you couldn't find the answers of most of the questions, right? Yeah. Me neither. Like I had to ask Mariano for most of them. But so let's go just one by one and see what you found. So which ministry is responsible for rehab in Spain? Does anyone have an answer? It's the Ministry of Health. There is a program in the Ministry of Education as well for children, but in general it's the Ministry of Health that's responsible for that. And is there an operational rehabilitation policy or strategic plan? I mean, I couldn't find one, and Mariano neither, so I guess there is no. Like I checked strategic plans, health plans of different regions like Aragon or Catalonia, but there is nothing mentioned about rehabilitation. So I guess there is not a strategic plan per se for rehabilitation. And then about the annual expenditure, it's also a very difficult thing to find. I couldn't find information about that, but one thing that I know that there is no country in the world that like subsidizes rehabilitation enough in order to provide coverage for everyone. So Spain, in this sense, also provides certain percentage, but it's not what we wish that it should be. And then, does health insurance cover rehab services? What do you think? Yes, yeah, it's part of the health insurance that you get. Is there any out-of-pocket payments, or do you know if you have to pay for rehabilitation? Yes? Okay. Okay, yeah. Okay, yeah. So there are certain services that are not paid, but in general, for example, physiotherapeutic sessions normally are covered. And what about the number? Did you find some numbers of workforce? So physiotherapists, do you know how many? Anyone? 5,000. Much more. 50,000. Okay, yeah, 51,000 according to 2017, the last information. And occupational therapists? Sorry? Well, one source that I found online says that there are 4,800, but the ones that are registered for in the World Confederation of Occupational Therapists says 7,800. So yeah, I personally couldn't find anything about speech and language therapists or audiologists. I don't know if you could, but yeah. And then about the prosthetics and orthotics, the ones registered in the association, the World Association for Prosthetics and Orthotics, it's just 9, but I guess that it couldn't be 9. Yeah, but there's no official information about like how many are actively working. And then Physical and rehabilitation doctors, 400. I don't know if you found this online. 400 active. And psychologists, how many? Yeah. Okay, and so do you know anything about the service delivery? So do you have home-based rehabilitation provided, included in your health insurance? Yes, you have. And rehab in schools? Yes, you also have. You also have return to work, vocational rehabilitation. And yeah, the answer of the next question is easy because you have it provided in hospitals, but do you know if you have it in different service provision platforms? So for example, secondary or tertiary school? Yeah, you normally have it. You have as tertiary some specialized, for example, in Toledo, Mariano told me that there is one specifically for spinal cord injury, the only one in Spain, or the Goodman Institute for Neurological Disorders. It is also a tertiary specialized center. And so do you know if there is any rehab related data that has been collected? Like the answer of these questions is yes. So you have information on the rehabilitation workforce normally collected, or access to services, or for example, information normally on impairments, but not on performance. So very few countries actually collect information on the performance or the functional abilities of patients. For example, in Australia, they normally do assessment, not just recording your symptoms, but also, for example, if you can do certain tasks, like if you can wash yourself or if you can eat independently and these type of things. And the final one is about the emergencies. Do you think that there is an emergency response plan? No, there is no here in Spain. So, I mean, this exercise, I don't know how interesting you found it, but it's just to show that, of course, you didn't have enough time. You were just, Googling for like 15, 20 minutes. But even if you continue, you just can't find the information. It's not available. And in many cases, if you directly ask the person responsible for rehabilitation, he also can't answer these questions. And I'm talking about high-income countries as well. Like, we haven't worked directly with Spain, but I can tell you in countries like, I don't know, Greece, for example, or Italy, it's just, they don't know this information. And imagine what happens with some low and middle-income countries. So the thing that you did now was just one part of the situation analysis. So you know what's happening with rehabilitation in the country. But the second very important thing is to know what are the needs of the population. So how many people, for example, have a certain condition, how many people require rehabilitation. And the way we estimate this, because it's different for each country. For example, in African countries, you have more infectious diseases, and in Asian countries as well, but you're not going to have them here in Europe. So the way we do it is through the Global Burden of Disease study. I don't know if you have heard of this. It was created at WHO in the 90s by one guy, Chris Murray, who then left WHO, and he created his own research center in Seattle in the United States. It's basically the biggest epidemiological study that exists in the world, like the most comprehensive one. It provides information for more than 350 different health conditions, and information like, for example, number of deaths, or more like morbidity, disability, for example, data, prevalence, incidence, everything. And it's updated every year. So this guy is also a very good businessman. So I don't know how he achieved this, but he receives every year funding from Bill Gates, and only last year he received $350 million for this. So now he has people everywhere in the world that are doing also on-site collection of data. So it's normally the data that they have here. It's through doing systematic reviews, or getting governmental or hospital data, or, for example, censuses in the countries. And it provides data for each country, for each region, and also global data. Of course, for some country, he doesn't have data because there's just none. And what they're doing is a very sophisticated statistical modeling. So based on what he has from, let's say, countries around this one, he's doing like imputation. What this means that he basically creates a model that tells you what would be the population with, let's say, stroke or diabetes. So it's one can say that it's not very reliable, but what he's saying is that it's pretty much it reflects the reality. And actually, it's I think it's going to be very interesting for you because I mean, this is the link. I will show you now how it works. You can access it. It's freely available for everyone. The link is long, but if you just Google GBD results, and then you will get it. So I will just demonstrate how it works now. So you have this, imagine that this is a database and you want to see, let's say, you have here like cause means health condition. You have different types of, search categories, like you can see life expectancy or impairments. But let's say we're interested in health conditions and you have different measures here. For example, do you see it or should I? Okay. Like you can be interested in how many deaths you have, or for example, let's say prevalence, how many people have a certain condition. Then you have a location here, so you have all the countries in the world. You have like you can find global data, or even for some countries you have cities as well. But let's check Spain. Sorry. Spain. Then you have different age groups. Like you can see here, it's you can do it by 5-year age categories, or you can do all ages. Let's see, for example, all ages. Here you can choose sex, so males, females, or both. And here, years from 1990 to 2017. So let's see what's going on in 2017. And then you can choose here if you want a percentage, or if you want number of people who have this condition. And then here are like the different categories, so the different health conditions. So let's say HIV. You want to see how many people in Spain have HIV. So what's the prevalence? At some point, you have at the beginning the infectious diseases, and then you have non-communicable diseases. So let's check 1 or 2 non-communicable diseases as well. So, for example, cancer. Let's see, these are all types of cancer. Stroke. Let's see how many people, for example, had stroke. And I mean, you certainly have had depression at some point in your life. So let's. It was found that how many, I don't know how many percent exactly, but it was more than 50% of students at some point during their career have depression. So maybe you're going to be interested in this. Let's see. Sorry. Okay, major depressive disorders. So you just select whatever you want, and then you click on search, and you see here that, for example, the prevalence of, sorry, these are all causes, but the prevalence of HIV, for example, 240,000 people have HIV at some point in their life in Spain. You see that 778,000 had stroke or will develop stroke. Then you see that almost 2 million people have depression, and 1.5 million people have cancer at some point in their lives. And the good thing about this is that, for example, if you are, let's say, interested not in prevalence, but so the deaths, how many people die, you can also see the difference between 2017 and let's say 1990, how this changed. It gives you a graph here, and you can see that, for example, the sorry, I will just remove these all clauses here because it's skewing the. So you can see here what happens, like how many people die from. So the orange one is cancer, and you see how from 80,000 people who died in 1990, now you have 100,000. So there are more and more people dying from this. Then for stroke, you have actually a decline. And then for HIV, things are pretty much controlled. Apparently, around 1995, there was a peak, but in general, things don't really change. And of course, because medication is covered here for people with HIV. But basically, this is an interesting tool that you can use if you want. And this is how we get information for a specific country and for the specific diseases that we think that need rehabilitation. And then based on this, we develop the plan. So the next project that I will present is called Package of Rehabilitation Interventions. So imagine that a country doesn't provide rehabilitation and they have to start from somewhere. So here in Spain, you have pretty much like most of the evidence-based interventions that are provided as part of the health system. But in other countries, you don't have it. So you have to select from these, from all the interventions, you have to select certain ones that are at least the basic ones that you need. And this is what we're trying to do. So why do we work on this project? Because it's essential for low resource countries, so for poor countries, to move towards universal health coverage. And universal health coverage means that you have a certain number, so a certain set of interventions that you will provide and people don't have to pay for it. So this is the starting point to build on. And then, of course, if country decides that they have more money and they want to expand this, they can invest in more interventions. But this is the starting point. And what we're doing is to ensure that these interventions are delivered based on the needs of the populations, not, for example, on priorities of development partners, on funding bodies. What I mean here is that, for example, in many African countries, because they don't have money to develop their health system, they rely on someone like Bill Gates. And Bill Gates is interesting in stopping HIV. So he delivers millions of dollars just to stop HIV. And the problem is that in this country, maybe there are more people dying from other things like diabetes because they just don't have the health care, that they don't receive the care that they need. Or maybe the priority there is cancer. But there is no money because all the money goes towards stopping HIV. And this is what we want to avoid. And we want to really develop this package in order to reflect the real need of the population. And these interventions will be provided at all the 4 levels, so at the community level, so homes, schools, workplaces. They will be provided also in primary and secondary care like district hospitals, then tertiary care like the specialized centers. And we're not going to just stop by saying this is the intervention you have to provide. What is the idea is to say what is the workforce that you need to provide this intervention. So what is the equipment and consumables that you need? What are the assistive products? Because some interventions might include provision of some assistive devices, and also what is the infrastructure? So how many facilities, how big these facilities should be, etc. So a little bit about the methodology, how we developed this. We started by selecting the health conditions because, as I said, what we thought is that we have to see what the need of the population is, and this is a starting point. And we want to see which are the conditions that are like relevant in this country. And then once we have the conditions, then we can see which are the interventions that work for these conditions. So we used on one hand data, as I already showed, from the Global Burden of Disease study, and just in order not to miss something, we also got suggestions from different rehabilitation experts. And there were 3 factors based on which we decided which interventions will be included. And this is the first one is the level of disability. So we want to see if a certain condition is associated with severe levels of disability, and we're sure that we have to provide rehab for this. The second one is the amenability to rehabilitation, which means that if rehabilitation is beneficial, because for some conditions, even if you provide rehab, just the evidence says that it doesn't really change the life of this person, it doesn't improve his condition. And we wanted to see if, like for certain condition, the rehab is beneficial. And then the third one was apparently the prevalence. So how many people? Was it like you know, an important condition, or was it a relevant one or not? And then after that, we grouped them in different groups, like musculoskeletal conditions, or neurological, cardiovascular, or respiratory conditions. And then we checked, of course, like, because, you know, the health condition can be different if you're a child or if you're an old person. So they have to be relevant for each age group. And how to select, I'm sorry, it's too much text, but I just wanted to show you like an example of how we categorize and which interventions we included and which we didn't. So we had like 3 levels. The first one are the high priority health conditions. They certainly have to be in this package. And how did we choose them? Based on 2 criteria. The first one is, so the health condition is associated with with moderate to high amenability to rehabilitation, which means that rehab is working very well to improve this condition. Then high level of disability and high prevalence, for example, stroke. Stroke should be definitely included in this. Then imagine that rehab works very well for this, and there is a high level of disability, so the person is really suffering. But there aren't many people, so many people in the country, for example, with spinal cord injury. We still think that this should be included in the, even though there aren't so many people with spinal cord injury, they should be included in this package. And then there is level 2. So these are the ones that we say it's good if you include them in the package, but even if you don't, I mean, if you don't have the money to include so many interventions, then, you know, you should leave them out. But of course, like, it's better if you do it and if you include them. And for example, these are health conditions where rehab is working well, but people don't really have high levels of disability. But there are too many people that have this. For example, ischemic heart disease. I think this is like, we think that it's important also to include this one. And then the last one is the health conditions with good amenability. So rehab is working well, but low levels of disability and low prevalence. For example, soft tissue injuries. We still think that it's relevant since rehab can actually help these people. And then the ones that we exclude are the conditions where rehab is basically not working. Even though there might be, I mean, the disability might be very high, or there might be many people with this condition. For example, schizophrenia, there aren't many people, it's around 0.8 to 1% in the population. But it's just for these people who have very severe schizophrenia, you can only help with medication. Even though nowadays it's a questionable thing if medication works or not. But anyway, it's not rehab that will actually help. So this is the way we selected these conditions. And right now we're doing literature reviews in order to see what are the interventions, the evidence-based interventions for these conditions. And then we will decide like which one to include in the package. Then the next project is called Rehabilitation Competency Matrix. And this is about the workforce. So until now, we were talking about interventions, about support packages. But now it's also important to think about who are actually providing rehabilitation in the countries. And this is the workforce. So, like, if you check the literature and if you see different frameworks that exist, normally what countries do is they just say, okay, we need this amount of physical therapists, we need this amount of occupational therapists, or for example, speech and language therapists, and then we are done. But the problem is that this doesn't work because in many countries, there is education only for physical therapists. You don't have any education or training for occupational therapists. And then what happens is that people who really need occupational therapists or speech and language therapists, they go to physiotherapists and physiotherapists don't know how to treat them, or they go to nurses if there aren't any physical therapists. So we really have to change this and to create a competency matrix, which means that we have to teach people of like basic skills that they have to know. So let's say if you have only physical therapists, they should know basic skills if someone comes and needs an occupational therapist, or behavior, so how to behave, attitudes, so how to communicate with the person in need, and what is the knowledge. So they need to know like certain things in order to provide good rehabilitation services. So basically this project is about shifting from these traditional health workforce systems that are orientated around clinical specialties towards more population need focused approaches. Because the thing is that when we're creating this project, the idea is that we will go to the country and then we will make this assessment, we will see what the country needs. So maybe there are too many people who have cancer in this country and they need specific type of rehabilitation intervention. So we have to teach and train the physiotherapists how to actually respond to this. And the novelty about this project is that it's the first one that is professional neutral framework. So it doesn't really matter if you are a physiotherapist or if you are an occupational therapist. You need to know these basic competencies. And I'll show you here, like, because I'm saying that it's a novel approach, I will tell you how normally things worked before. So there were utilization-based like workforce approaches, where you see, for example, most people use services in order to get help for HIV or cancer. But the problem is that maybe in this country you have to pay for rehabilitation, and then only the rich people use rehab services, which means that there is like 1 million more people that need rehabilitation, but you don't know anything about them because they cannot afford it. The problem is that when you're doing the policy, you're just thinking about the people who use rehabilitation, and this is not good. Then the second type of frameworks are the worker to population ratio. So you know that you have to have 700 occupational therapists per million, and then your problems will be like just done. But that's not the case, because maybe these people don't know how to act in different situations. They're not prepared if you don't have, for example, speech and language therapists and someone needs help for this. Then the target setting based is, let's say you decide that in every region in Spain, you will put one hospital for cancer. The problem here is that maybe in Madrid, there are too many people who have cancer and there aren't enough beds for them. So there are many people that are left behind, you know, they can't access the help. But then you go to Andalusia, for example, and there aren't so many people who have cancer, so you have a lot of beds available. The problem is that you have this like inequity actually, and that's why we thought that we have to start from the needs. You have to first see what the population needs, and then you create this competency framework. And it works like this. So we identify the needs, and then we find the interventions that will target and address these needs. And then we say, okay, for these interventions, you need the following competencies for knowledge, for skills, for attitudes, as attitudes or behavior. And then you have representation of these competencies in your workforce. It sounds very theoretical, and we just started actually working on this project, but the idea is really to change like the mindset of the people who are responsible for, you know, the strategic plans and rehabilitation in the countries, and to start actually providing better quality rehabilitation services. And yeah, this is the development process. So we just started. We will do systematic reviews, as I said, to see, I mean, what are the frameworks that exist, what are the gaps, and maybe some limitations, but also strengths that we can use for our framework. We will collaborate with different WHO departments, because actually there is already one similar existing competency framework that was created by the mental health department. So they already did this. And then we will, of course, ask experts about their opinion. And the good thing is that we also ask patients who use rehabilitation to actually know more about what do they need when they go and see a physiotherapist, what is the attitude that they need, and do they get it or not, or you know, the same thing for occupational therapists. And then next year we expect to launch this and to start implementing it in countries. So then this was the second area of work, which was the strengthening health systems. And the third one is research and evidence. As I said, we use certain methodologies, research methodologies also for the health system products, but this one is really oriented towards research. And I will show you here one project. It's called the Global Status Report on Rehabilitation. So when I presented at the very beginning the whole agenda, I said that by 2030, so it's called Rehab 2030 because by 2030, the ideal situation is that every country in the world will have rehabilitation integrated in the health system and people shouldn't pay in order to get services. Of course, this is an ideal situation and I'm sure that it's not going to happen, but at least we need to see if there is some improvement if they follow these 10 steps. So basically with this project, what we want to do is to make like a screenshot now of the situation in every country. So what is it there? Like, what are the needs? What is the provision of rehabilitation? And do this every 2 years until 2030 in order to see the progress and then see what are the gaps and limitations, where did we go wrong, and what was actually working. So here we will do a survey. It will pretty much look like the one that you already used. So it will collect information, but not really going deeper into, you know, the whole strategic planning and policy. It will be just information about the country. And you can see here the development timeline. So again, 2020, we're expecting to have the first one. And it should look something like this. This is just one page of the information, but imagine this is Botswana. You have like, what is the population? And then you have the part on leadership and governance. So you will know who is responsible for rehabilitation, what is the expenditure. So pretty much the questions that you already had. Or also we will collect information on the number of different rehabilitation professionals, also information management if information is collected in the hospitals, etc. So this was very quick because it's still in the project. It's undergoing, but this was the part, like the more research methodological part that we're working on. And the fourth area that I wanted to present is emergencies. So what we are doing in terms of emergencies. So the objective is to provide standards and resources to support the integration of rehabilitation in emergency medical response teams. So you might find it interesting, but in most of these humanitarian actions that you see on the TV, there is nobody that actually provides rehabilitation. Like everything is just treatment, so acute, phase treatment. And then what happens with these people if they need rehabilitation after that? Nobody knows. They're just left there. And we want to make sure that there is always someone, a specialist, that actually will help these people and will provide rehabilitation in the acute phase. Because there are so many people who suffer an injury, like imagine if it's an earthquake or a war. They will suffer an injury in a disaster. They will require a rehabilitation because rehab can, maximize the impact of the surgical and other medical interventions, reduce length of stay in the hospital, prevent any complications like contractures or pressure sores, or reduce the person's need for ongoing care. And of course, people can then go back to work faster. So there are many trainings and documents that we develop, but one that is, I think, interesting for you is a little book that we published last year. It's called Minimum Technical Standards and Recommendations for Rehabilitation. And it basically provides recommendations in order to include rehab services in emergency medical teams, provides information on what are the equipment and consumables that you need, or for example, what is the facility, like how big should it be, etc. And then it also provides some field hospital space recommendations, yeah, as I said, or specially care teams with rehabilitation. And we made a video that I want to play here that will explain a little bit more about these minimum technical standards. It's a 5-minute video, but I think you will find interesting. So these are the people responsible for doing this.
2 years after emergency medical teams responded to the 2015 Nepal earthquake, many of the 22,000 people injured during the disaster are still rebuilding their lives. For some, recovery will continue for many years to come. After disasters, emergency medical teams save lives by providing trauma care and surgery. Now, more teams are realizing the importance of integrating rehabilitation professionals in their initial responses to give those they treat the best outcomes possible.
This was the first time we embedded rehabilitation experts and thinking about rehabilitation needs in the first week inside the emergency medical team coordination cell. And it became very clear within the first few days of the response that there was an overwhelming trauma need, but also the numbers of rehabilitation cases, or cases that were so badly injured that they would require long-term rehabilitation, clearly far higher than the local needs could manage. And that many of the teams who had arrived hadn't thought about rehabilitation in their management system or how they could possibly help. We really see surgical care and trauma care as only the first step on a long road for a patient. Rehabilitation is a big part of that journey, and the earlier we can think about it, the better it is for the patient.
We had a good, learning from the other disasters, like from the Haiti, that we have to have a good plan for emergency response, treatment, and at the same time, rehabilitations.
For Nirmala and Kemro from Kathmandu, it was a tough path to recovery. Each of them had a leg amputated due to injuries sustained in the earthquake.
Kendo and Nirmala are 2 girls, they are children. So we saw them on the second day of earthquake in National Trauma Center, and where there was no rehabilitation service. So after the amputations, the rehabilitations was so important for them, because our long-term aim for them was to make them stand and walk on the prosthesis. Now they are going to the schools, now they are playing, they are enjoying their rights as a human.
Earlier responses by emergency medical teams after the Nepal earthquake saved lives. With introduction of rehabilitation at the beginning of the response, people with impairments were able to achieve better mobility and quality of life.
So many young people were injured in the earthquake. For example, a patient, he's a young guy, around 20 years old, Kesh Bahadur Guru. He used to work as a trekking guide. While going on the rescue in his very remote area, his truck fell off the cliff and he had a spinal cord injury.
And after the hospitalization, I came here for the rehabilitations because at the time I don't have any sensations, and at the time I have stomach infections and so many problems. So for that management, I came here for the rehabilitation. Since without the rehabilitations, the people who got a spinal cord injury, they will not live longer.
There were a lot of lessons that we learned from Nepal that will really help us be more effective in the next sudden onset disaster. With rehabilitation, we showed that you can reduce the lengths of stay for patients in the acute care environment, because we were able to get them up, get them walking, and get them back into their communities as soon as possible.
WHO is working to strengthen the integration of rehabilitation into future emergency responses by including standards for rehabilitation in the verification of teams. The standards mean that teams can now provide better quality rehabilitation from much earlier on in the response. The standards for rehabilitation in emergencies mean that teams must now deploy with at least one rehabilitation professional per 20 beds. They must bring certain equipment and consumables with them that are important for rehabilitation, and that when they're going to be there for an extended duration, they allocate a specific space where rehabilitation can be provided to patients.
For some patients who have gone through a life-changing injury, rehabilitation can help take their life in a new and positive direction.
After completing my rehab, the SIRC, they gave me job here as a paid counselor. And now I motivate to other wheelchair users.
Kesva and Nirmala and Kemro's stories had positive outcomes because of the care they received, with strong rehabilitation efforts integrated into future responses. We can give many more people the happy ending they deserve.
We really need every EMT to feel it's part of their role to start the rehabilitation process the moment they start trauma care.
It's important for EMTs to realise that rehabilitation needs to begin with them, but that will also continue long beyond when they leave. Having a rehab provider within their team allows the patients to get the earliest access to care, but also to link them on to the appropriate follow-up services.
By achieving the World Health Organization standards, emergency medical teams can ensure future responses will see better quality care and more people leading productive lives.
So just to show you here some infographics based on the document that we just discussed. So for example, recommendations for skills and competencies. As also mentioned in the video, so you need at least 2 years of clinical experience in order to do this job, or you have to have certain skills that, like for example, know how to do splinting or provision of psychosocial support or respiratory care or patient mobilization assistive devices. In terms of team configuration, you need one rehab professional for every 20 beds, and you have to also make sure that, for example, the nursing staff can also be used to augment rehabilitation capacity. What is the equipment that you need? There is a certain set that needs to be available in every emergency situation that includes, for example, walking frames or bandages, inpatient wheelchairs, adult and pediatric crutches, compression bandages, etc. This is all available on the WHO webpage. So if you're more interested, for example, in checking in detail these documents, you can access them there. And for example, information management, this is something that it's forbidden always. So you need to keep track of the record of each of the patients, and also have a very good referral system. So if you need to send them to a more specialized center, you have to keep a record of everything that you've provided and the functional status of this person. And the final thing that I didn't mention it before, and it's not part of the 4 areas of work of my team, because I don't know why, but assistive technology is like something that has been done by another completely different department. So basically we don't have the final word. Normally we are in collaboration, but everything that they're doing is their job. But I will present one project that they're working on, and this takes like maybe 80% of their time. It's called Global Cooperation of Assistive Technology, or GATE. And it's very important because on a global scale, only 1 person in every 10 receives the assistive technology that they need. And of course, you can imagine this is normally in high-income countries. And so this initiative, GATE, is basically, its objective is to improve access to high-quality, affordable services, technology for everyone in every place or in every country. And it has 5 main, let's say, areas. So the 5P, as they call them. So the people, they want to make sure that all the users and their families are involved when the policy of the country has been done. So they use a people-centered approach, And this is critical to make sure that users' needs are addressed when the governments are doing policies about assistive technologies. The second one is policy. And here WHO is developing a tool to support countries in developing policy and program to ensure that everyone gets the assistive products that they need. And this is a toolkit that will include assistive technology guidance, also financing information, so how much normally each of these products cost. Also, programs, so how can you apply for these products, etc. Then the third one is products, and here WHO created a list of 50 basics, so the most important products that surely have to be included and provided by the governments, like wheelchairs, for example, crutches, and all these. The fifth one is a provision. So WHO is developing the so-called assistive products training package. So sorry, this is provision. Yeah. So basically, it's like the components are. It includes the integration of assistive products, service provision into the health system. So basically, it provides information on the referral system. So if someone needs, for example, let's say someone in primary health care level sees that the person needs a certain assistive device, they have to refer this person to, let's say, secondary level or tertiary level care. So it's just to make sure that this referral system goes smoothly and that the infrastructure is there and that it will enable people to access the products that they need. And the last one is the personnel. And here also there is a tool that has been developed to train people who actually provide the assistive devices, how to teach people to use them, because it's important not just to give it to someone and say, from here on, it's you. So you have to really teach this person how to use it. And then if they have problems, what to do, how to get back to them, etc. And so this is pretty much what the assistive technology department is doing. It looks like something small, but actually it's constant work with countries in order to improve this and to develop all these tools. And they're a relatively new department. So this was, in a nutshell, the program of rehabilitation at WHO. I hope that you found it interesting to see how it works, and maybe, I don't know, I don't know, awakened your curiosity. Maybe you'll be more interested in public health work or research after you finish your careers, if you don't want to continue in the clinical path. But if you have any questions, so this is the, I've left here the web page, WHO Rehabilitation webpage, where you can find information about everything that I just presented, all the tools, all the research methodology that has been used. And this is the Rehab official email, and also my email. If you have any questions and you don't want to ask them now, you can always ask me. If you're interested in doing, for example, even internship there or whatever, you can always contact me or directly the assistant that answers the Rehab email. And if you're a Twitter user, this is the hashtag Rehab2030, where you can find some more information. So thanks for this. If you have any questions or comments or suggestions, I can answer now, or if you don't, you can always email me and I will answer.
Okay, so if you have any question or any comment, okay, we will try to use the microphone. No, it's for, well, actually the session is being recorded in the streaming, so it's better if, okay.
Thank you. Just about the response that working. Just about the role of the physiotherapist during the rehabilitation about the response in the human process. Just you showed a short video that was interesting, pretty not a good. You think about if it improve that could be improved the physiotherapy there and what is the more
yeah. I think I got your question. Yeah. So I have to admit that I'm not working in this area because I'm not a emergency person. But normally, like, because the profession that is mostly required in emergency situation are the physiotherapists in general, and so in terms of improvement, there is not actually anything about improvement, just because in general there was nothing until now. So physiotherapists were not included in the medical emergency teams. So the first thing that we recommend is to actually include at least one person that has to be there, and this person has to first of all have the environment in order to work well. So starting with the facility, like you need like certain space in order to work, and then all the consumables that he needs, all the assistive devices, etc. So basically, this is it. There is nothing concrete about physiotherapists in general, but also another thing that is important is that if there is space, let's say the emergency medical team, they have funding for only one person who is a rehab person, and this person is a physical therapist, then he has to have these certain competencies, the knowledge, in case someone needs, let's say, occupational therapy or speech and language therapist to provide this. So he has to have this set of competencies. Yep. I don't know if this answers your question, but yeah. And if there is, you can really always email me, and I promise I'll respond very quickly. Yeah. The emergency, you mean? Or about everything? Well, I have to be honest. Normally, the WHO work, even though we say that we're a global organization, we target more or less low and middle income countries, because we assume that even though some things don't really work well in high income countries, for example, the study that we did about the rehabilitation needs, there were many countries like the United States where certain states just many people don't get the rehabilitation that they need. Or in many high-income countries like Spain, you have long waiting lists. So even though you have, rehabilitation provided, you have to sometimes wait a lot in order to get in the list. So there are always certain things for improvement, and of course we're open to work with any country. The problem is that WHO is not a legislative, it doesn't have any legislative power. So this means that when we do this project, it doesn't mean that the country is obliged to, follow this. It's a bit like on a voluntary basis. So if the country is interested, they have to contact us, and then of course we provide the technical support. But if they're not interested, it just doesn't work. Of course, we are also proactive. When we know that in a certain country there is a problem, we initiate the process and say, look, we know this. Are you interested in this thing? And then if they say yes, we continue. So in this sense, for Spain, you have universal health coverage, so this is the first criteria that a country should have. And of course, like I can't tell you if they will follow, because it depends on the person in the ministry that's responsible for this. But this applies for every country, and it can be applied in every country, so Spain as well. The decision is voluntary, yes. It really depends on the person here in Spain. Yeah.
Coverage is universal, but it forgets the fact that the access to it is very delayed in time. So
yeah.
Many of the patients have to go to the private sector to
yeah.
And also, it's also forgetting the fact that Spain as a state is is economic decay, and public funds for health services are still in decay as well. So in the future, we may find that this universal coverage is not that anymore, for example.
Yeah.
And so maybe your guess will be important for us.
That's true. Actually, universal health coverage is a very relative term because in Spain it might mean something. So you have, let's say, this set of interventions or services that you cover. And then in another country, you might still have universal health coverage. But if this country is not as rich as, let's say, I don't know, Germany, you might provide a smaller, package of and set of interventions that are included and you don't have to pay for. So it's not like every country should follow the same requirements. It really depends on the country. So in this sense, I know, and this is the main problem in high-income countries, that you provide a lot of services for free, but at the same time you have to wait a lot for them. And this is the case for every country, like Scandinavian countries, Germany, England. Like in England, I know cases from friends that you break your arm and sometimes you have to wait 2 days because, just for a doctor to see you. And of course, like they say, we have universal health coverage, everything is for free, but yeah, the waiting list, it's too big. And also, you're right, because with the economic crisis, the funding for health, the health expenditure might actually decrease, and even some services might be excluded from the list of free services. So it really depends, and it's all about the money at the end, and and the will of and the leadership of your ministers. Yep.
When you talk about the levels of disability, how do you define the patients that have a higher level of disability? That you said stroke patients are in the level 1, and patients with heart failure are in level 2. How is it defined? Which scale do you use to define?
Yeah, well, it's an interesting question because there are two sources that you can use to do that. One is the global burden of disease that I just presented. They have a scale from 0 to 1 for every health condition. And then they have this, it's called disability weight. So this is the level of disability that a person with this condition can reach. So in the worst case scenario. And then you have, for example, schizophrenia or spinal cord injury, traumatic brain injury are at the top. And then you have things like having a caries or, I don't know, like a very mild low back pain that have a very low level of disability associated. So this is one option. You can see the list of 350 available conditions and you can see the disability level. The second thing that it's WHO tool that we developed in the disability unit. It's to basically collect population-based data from a country through a very comprehensive survey. It's called the Model Disability Survey. So it asks many questions about different functional domains. For example, if you can eat, wash yourself and everything, and then this is related to different conditions. And then you can determine, based on your conditions and these questions, like what is the disability associated. So we have there like cutoff points of, let's say, if more than 20% of the answers are answered this way, then you have like moderate. If more than 60% of the questions are answered in a way that you say that you have problems having this condition, then you have severe disability.
Also that there is a big difference between providing therapy in developed countries and places like in Africa or other countries. And not to give differences and what is the position of the whole organization. But is it better to future physical therapy to continue improving the knowledge about physical therapy and like in specific this or this going to this and not this, which is very specific, or reducing inequalities and work on those different countries and try to spread the physical therapy.
So about physical therapy, like speaking about low-income countries, the first thing that we have to do is to actually have physiotherapists, because there are some countries without any physical therapists available. Then the second thing that you have to make sure is that there is education provided for physical therapists, because in many countries there are nurses who say that they provide physical therapy, but they're not trained in providing physical therapy. So the second thing is the education, and this is very important. So they have to be trained, and they have to know like a certain skills and you know, a knowledge in order to provide this. So the position of WHO in this sense is we don't really differentiate between countries. So we just want to make sure that if there are people who really need physical therapy, you have the people to respond to this, so the workforce that is needed. And in this competency framework, so don't get me wrong, we're not saying that physical therapists should know the job of occupational therapists. It's just for countries where you don't have, you know, different professions. They should know at least some basic skills and knowledge in order to help everyone. So in this sense, you're not gonna study and learn different things that what you're studying now. We are still, you know, for the education in physical therapy to produce, you know, more and more specialists, and you should know what you already study, but it's just, the good thing will be to also have some extra skills in terms of, let's say, if someone needs a different type of help. But in high-income countries, things in general work well in terms of, I mean, education. You have now very good education. You will become professionals, and you will be able to, you know, practice. So there is nothing really like, there is not a big change that we are suggesting in this sense. Yeah. Well, if you don't have any more questions, then
no more questions, no more. Oh, it works right now.
Yeah.
No? Are you sure? No? You don't want to take advantage of make? No?
Okay.
No questions, no observations, no comments?
Okay.
Okay.
Thank you very much. You're a great audience.
Start at 3:30, okay? It's not geriatrics. Geriatrics is at 3 p.m. Yes, I sent you a message this morning, so telling that geriatrics class will start at 3:30, but it's not 3:30, it's 3. It's the research class that will start at 3:30 p.m., okay? I make a mess, sorry.